Advocacy for better health is built on the premise that if citizens are aware of their rights and responsibilities, and civil society organizations have the capacity to empower and represent communities, they would have the confidence to hold their leaders accountable.
It is the duty and responsibility of the government of Uganda to provide health care for its citizens. Health is a right. It is not optional. And since the government has that responsibility and the mandate and the resources, it became necessary to have advocacy because we believe that within the government systems, there are improvements that can be made.
Empowered communities have the motivation to get organized, discuss and reach a consensus on their priority issues and plans, and to take action and demand for better health and social services from their duty bearers. Advocacy for better health has an objective of improving availability and accessibility of quality health services in Uganda. It supports citizens to demand for their rights and to be fully engaged in planning and monitoring of health services. In addition, it strengthens civil society organizations to conduct advocacy that can improve health-related policies, budgets, and programs. It also strengthens the institutional capacity of civil society organizations to obtain, manage, and implement long-term sustainable advocacy projects. It is implemented by PATH, Initiatives Incorporated, and 22 Ugandan civil society organizations covering 35 districts in western, central, and eastern regions of Uganda.
We do implement other programs, so many other programs, vaccines, immunizations, family planning, maternal and child health. So we use those innovations and ideas from those specific programs. Then we use the advocacy for better health to actually drive the advocacy.
The persistent collective voice and actions from citizens and civil society organizations compel leaders and duty bearers to respond by changing the necessary policies and taking other actions that can lead to improvements in the availability, accessibility, and quality of health and social services.
It's a game changer. It helps everybody to realize his or her roles. And because of that interface, again, we understand each other better. Rather than everyone complaining, we find ourselves working for a common goal.
The project is designed to directly contribute to improvements in delivery of services for HIV/AIDS, TB, malaria, nutrition, reproductive health, and maternal and child health.
We have awareness sessions in communities per sub-county. In every sub-county, we selected one active community group, an existing community group, that we introduced to this aspect of advocacy.
Over 400 community groups have been educated on their rights and responsibilities related to health and social services. The communities have been able to demand for policy changes from decision makers and to hold them accountable for the quality of health services. One example is Jewa Health Center 3 in Mbale district, which never used to receive drugs from national medical stores because it was not appearing on their drug distribution list.
Twali tulina eddwaliro nga ddwaliro budwaliro naye nga temuliimu ki ddagala. Twatambuzza ekintu ekyo ne tutambula paka okutuuka ewa DHO nga tukaaba kiki kya ddagala, tukola public hearings, tuyita abantu sub-county number ne beewulirako ne batuwa ebirowoozo ne tubeera nga tubituusa paka ewa DHO paka lwe twatata ne mafooko nayo ng'etuyambako paka lwe twafunye eddagala ku ddwaliro.
If these meetings had not taken place, I don't think we would have been registered under national medical stores because we were able to document some of the things that were mentioned in these meetings in form of minutes. Because even when we lobbied the district and Minister of Health, we were always attaching the minutes of these community meetings, the attendance lists, and that was evidence enough for Ministry to prove that really our communities had a need.
Advocacy for better health has been working with partners and the media to avert a national stockout crisis of anti-tuberculosis and HIV treatment medicines and supplies.
I would go with my recorder, get these voices, record them for about 30 minutes and I don't edit them. We run this recording in the native language. Native language. If it is Rumasava, the program is Rumasava, is understood and listened to by the communities in their particular language.
This is being done by raising both the national and international profile of the stockout crisis and working with networks of people living with HIV at national and district levels to collect evidence on stockouts in all the districts.
We have a team of people living with HIV on the ground. Some call them expert clients, others call them linkage facilitators or community support agents who are actually supporting their peers at the health facilities, and they collect data. They are the people on the ground who give us the report on we have this stocked out, we have this available, or within 2-3 days we shall actually not be having any drug at all.
Ruwero Health Centre 4 is one of the health facilities where a lot of success has been registered.
Eddagala eryo bwe lyabuliramuko basobola okubaako awalala we tulijja nga tukubayo ne batuwa eddagala naye nga tufuna eyali badde afuna omwezi gumu ng'ofuna wiikisi 2 ennaku 3 bwe tutyo nga bagenda balobinga paka okulaba le batutereereza eddagala okusobola okuba nga lijja.
Eddagala ndifunira wano e Kasana era bwe nazze nfunye bulungi eddagala lyange lya myezi 3 omusawo mulabye eddagala lyange balimpadde bulungi. Tutu bwe najja kale nga ndi mulwadde nga sisobola na kutambula naye kati nafuna amaanyi eddagala lyange ndimize bulungi nfunye amaanyi kati nakomerera eddagala emyaka 4.
Whereas the issue of stockout still remains, but the magnitude has completely reduced. And that's why we talk of sporadic. It is not something that is consistent. Like we go to a district and find that there are no drugs 1 month, 3 months, 6 months, 1 year, which is to be the case. Right now they are sporadic and you do not find all the regimens lost. So what I can comfortably say is that working with Advocacy for Better Health, the support that we've been able to receive has been able to help us generate the evidence, which evidence we've used to advocate and engage and lobby and negotiate so that the drugs, whether it is following the normal routine, the normal cycles, or even if it is a quick buffer to alleviate a crisis here and there.
Reinvigorating Health Unit Management Committees, HUMECs, to provide an oversight role in the delivery of health services at health facility level is one area where Advocacy for Better Health is registering success in reducing staff absenteeism.
My roles here, I do monitoring on the behalf of the community. So they interested me. So with the other 6 people, we are 7. We do some monitoring of the service which is going on in the unity. We usually visit in a week. We can visit the unit about 3-4 days in a week to see what's going on in a week. Are the staff members working? Are they attending? And other things.
In Sironko District, Wijitima Health Centre 3, the midwife's poor service provision had left delivery of babies in the sole hands of a night security guard.
The askari, the security command, the local security guard would help, was the one who had now become as the midwife who would help mothers deliver. And he testifies it because I have even a recording for that.
Anganduire, nembonete midwife karu, myaka jochi, imi indeda, abe saris. Nga chiro bude nga basala chiro musi gutike babonekara tananga nabona ngefula yakubrenjo yekali nichidima bas uleo muyeda akulike
ndanga mwanzi ni mwana nikasaa neza kwenyuka mwiro sanga zitano kuchikupanga ko bitu kola kupanga ko bitu ngayobone bye kwiga yasaga ko binanu kachi cyese mupanga panga gireko bas kwatula kuza kudabula kwidwalo kodiyanga kako musawe sizana eba musikale noliko ngendi bubi basi yo kina novanga okuyenda tebakendi kusobola kujenda.
Thanks to the active health management committee, the midwife was removed and a new one posted to serve in this remote community.
What I've seen from it, the service we are receiving, it is up to date now. You can see even the patients, pregnant mothers, they come in a large number. But during those times when I thought was there, they could not even come. They could come to me, chairman, we can't go there. Because she even stood there and promised to inject them just water. They come and sometimes say hello to me. They say, chairman, at least the service we are receiving is up to date.
Lack of staff housing, one of the major causes of health work absenteeism, was solved by completing a house where the midwife currently resides. Advocating to reduce health work absenteeism and improve relationships between clients and health workers leads to better health outcomes.
When they came in to advocate for better health, they found many of our centers not having boards, what we would call health unit management committees. And those who had, they were dormant, or the leaders really didn't know what their roles were. So they worked very hard that the boards were appointed and they were taught or trained on what their roles were. And that has improved so that we don't clash too much with the community. Once we talk to the board, the news can go out and people will understand that we are trying our best.
In Mpigi Health Centre 4, 2 more doctors have been recruited. With such a busy health facility, more doctors mean round-the-clock operation in the theatre, where mothers and babies in danger are saved through caesarean delivery.
Because as I stand now, the staffing norms, I'm actually at about 100%. But given the work I do, I should be having a staffing norm of a hospital. So we are advocating, we are working very hard for the powers that be to note that we need to go to hospital level so that the staffing levels will improve. I know we have advocated for doctors because I wouldn't manage with only 2 doctors in this center. We are now 4.
In Mbale district, community advocacy is improving health financing.
Because of these interactions, we had to advocate with the district to see that using various grants, we are able to prioritize health and construct some staff houses. So we constructed 24 housing units under the Office of the Prime Minister and SAF 2 project in order to have some of the staff resident at their health facilities.
Bujiri District Nankoma Health Centre 4 is improving staff housing.
They are constructing 2 apartments to accommodate the 2 doctors so that at least they all live independently. I think that will improve services if we have resident doctors at the facility. It was sad to note that 2 doctors were sleeping in the same house. But as a result of the activities, we've received a donation that is by Gavi. I think they had your cry out.
We do tracking at this facility on a monthly basis. The reason as to why we do track is 1, we want to know the number of staffs available. We want to see and know the number of staffs who are present on a particular day or in the whole month. We want to know the time and arrival of the health workers. We track to get information on the stock. In every quarter, we conduct 1 advocacy forum meeting. So we get this information we've got from these tracking tools. We present them. We write a paper and a position paper. We present them to the duty bearers or the stakeholders in the advocacy forum meeting.
We have had at least a constant supply of coatem without serving. If we get any malaria personnel, there is coatem available because we get more stocks.
We've seen, attitude of health workers improving because of the communities being aware of the way they're supposed to be treated, the hours health workers are supposed to work. So we are seeing a change.